little less intense from a scientific perspective. So, but by show of hands, who trained before the 80-hour work week? All right, good number. Who remembers these things called books?
Before the 120-hour work week.
Yeah, right. Who actually read Campbell's to prepare for exams and to learn about urology? Who actually had a Hinman surgical atlas and it reviewed steps to know what to do in the friggin' OR? Wow, you guys are my people. So there's been a lot of changes generationally. I remember rounding with a chief resident and asking questions about metabolic disturbances after urinary diversions, and they just whip out an iPhone, and we're like, well, what are you doing? Well, I'm looking it up. Well, don't you know it? I don't have to know it. I can know everything you know in a matter of seconds. And that's disheartening. And, it's not entirely false, but, there's some pitfalls there. Okay. And so we joke about, well, hey, doc, have you ever done this operation before? Well, I watched it on YouTube yesterday, or I stayed at a Holiday Inn Express last night. But we're going to talk about embracing video. And so the last question I'll ask before I get into my talk here is, who here thinks that they are the world's best surgeon and they have no room for improvement? Great. Right. And that's the mindset that we need to maintain throughout our careers. Okay. So my objectives in the amount of time that I have is to discuss how education for surgeons is changing and to highlight the need for what we refer to as continuing or continuous professional development, CPD. And we'll talk about video-based coaching and analysis, similar to what we use in professional sports, and maybe some strategies for optimizing your own personal performance. So we're supposed to be lifelong learners, right? We're supposed to be embracing this throughout our career. And there's this old fable, it's been applied to not only doctors but attorneys as well, but the doctor who treats himself has a fool for a patient, but likewise, the doctor who trains himself likely has a fool for a teacher. And this is one of my favorite quotes just because it highlights some of the absurdity of looking into the web for everything, but that everything on the internet is true. And of course, the source, tells you that it's not. So in terms of the bell curve distribution, how do we stack up? How do you know who's a good surgeon and who's less of a good surgeon? Skill itself is poorly defined, right? There's no concrete measure to say this is perfect or this is perfectly competent. We come up with some metrics to use and to define privileges. The majority of adverse surgical events are attributable to technical error, regardless of what we talk about with systems-based practices or systemness, like Tom was talking about yesterday at our critique panel. Okay, the proxies for skill, what we actually use when you apply for privileges, the fact that you just finished a residency, you're board certified, somebody wrote you a letter. These aren't necessarily adequate metrics, okay? But what are the challenges that we're facing? I already talked about work hours, but surgical technology is coming at us at lightning speed. How many BPH procedures did you guys raise your hands for when I was on the critique panel the other day? It's a lot, right? So, but clearly, if you have less time to learn, less time to train with everything we're trying to pack into someone's mind, that's going to be a challenge too. The unfortunate reality is that many surgeons fail to improve once they've reached proficiency, right? Can't be the best at everything. You got a lot of things you need to be able to do, okay? And the learning curve persists even after training, or what we refer to as our initial training, has been completed. So education has evolved. We have more to learn. Our trainees have more to learn. They have less time to do it. And the ones in training now, we talked about changes by generation. They want more personal time. They want time to themselves. They want you to be their bowling buddy. They want the faculty to come out, spend time with them, make them feel like a valued part of the team. Now, we can dismiss this and say, well, it wasn't like that when I was a resident because you went to work, you kept your head down, you put in all these hours and so forth. But that's not going to help you, right? We have to adapt to some degree. Now, the differences that we're seeing with each successive wave affects both learning styles and their preferences. And so, my kids are over here on the right, and I think about, what we were told to do as parents. Like we have Baby Einstein videos, you wanted a kid to be quiet in the store when you're trying to shop. Here's an iPad or, look at this phone or what have you. And then we get pissed off when we can't take their faces away from the screens. But, the people we're training now were raised by screens, and they're used to rapid delivery of information. That's the norm. So if somebody's saying, well, go read it, go learn about it, they might not have the patience for that. They want to watch a YouTube video and get the information quickly. And then, of course, when we were all locked up for the pandemic, that had an impact as well. So social media, I'm not on a lot of social media or much at all, but has risen in such a way that it's even become a support group for practicing surgeons. I'll see these emails, and I don't know how they get my email address, but people asking for input on a particular case. And it rotates through, and then you get all the reply alls like cluttering your in-basket. But people are leaning on each other through social media. Now, one of the reasons I like this meeting is look how many people are in here listening to a lecture. They came here, people like learning, but too often, CME events, it might be just a disguised vacation. Somebody might check in, pay their money, hopefully get their credits by sending in a survey, but then they never go to anything. So what about the Halsted model? Okay, if you go back to the 19th and early 20th century, surgeons preferred private practice and avoided teaching, they avoided research, and they didn't want to train people that might compete with them for business. So Halsted said, we need a system which will produce not only surgeons, but surgeons of the highest type, men, presumably people, let's say, who will stimulate the first youth of our country to study surgery and to devote their energy and their lives to raising the study of surgical science. So he changed the model, right? We went from apprenticeship to a residency. Halsted himself was a pretty lousy student, right? He never checked out a library book the whole time he was in school. He started in New York and then became addicted to cocaine and morphine. And then he went to Hopkins when their first choice backed out, and his career was actually on a downward spiral after that. And when they were pulling in people for residency, they only wanted unmarried men, right? So they had less distractions. They had to be available 24/7, 365. And then if at any point you weren't cutting it, you were out, right? And there was no specific cutoff. You weren't done training until they said you were done training. Can you imagine if we did that now? Crazy, okay? So, learning curves are not the same for everybody. We talk about, I hear these lectures all the time, how many whole lep cases do you have to do, right? You might be at averages, but some people are, pick it up more quickly than others. But the whole watch one, do one, teach one concept is a total fallacy. In a time of where all of our outcomes, everything's out there online, right? People blog, they talk, these surveys, right? We're starting to feel the need to be a little bit more heavy-handed, meaning, protective of our own surgeries when we have residents in the OR. The concept of, letting the residents get a little bit more involved, we accept maybe a higher risk of complications. I've heard people say cracking a few eggs to get there. That's no longer as acceptable, okay? So there's this big push to adopt all those new technologies I was mentioning, and that, can really add a lot of stress in practice because you want to meet the demands of the patients coming through the door. And assessing your place on the curve, knowing where you are objectively in terms of skill and outcomes, it requires an objective viewpoint. It probably requires some metrics, actually looking at the outcomes. It takes time to do that, but you also have to be interested. You have to care about the quality you're providing, right? Enough to take a step back and say, well, let's see how we're doing. There's a need to stay irrelevant, right? We now have cars that can drive without us, okay? We talked about AI a little bit in the critique panel, but in a lot of ways it can outperform us. Most ESWL cases would have been fine with you not even being there. And aquablation likely did more than you used to and in less time, okay? So here's what we know. We know that higher volume tends to be associated with lower mortality and complications. So, and because, no two surgeons are the exact same, it's difficult to define thresholds for proficiency based on a pure number of cases or the time spent training. So going back to what I said before with CPD, it's felt to be poorly served by traditional CME events, which were largely teacher-driven rather than learner-driven and didactic over truly interactive. And so the American College of Surgeons actually has a committee for this, and they offer mentoring and precepting. And this will kind of, feed into my discussion coming up on coaching. Self-directed learning, right, doing it on your own, requires deliberate practice and reflection, but this is improved upon by feedback. So when somebody says, well, I don't want anybody, I'll just go learn about it by myself, and they think it works as well, it doesn't. So I can be dismissive about a lot of things technologically, and my kids are hearing this now, and it's probably going to hurt my arguments when I go home, but we really do need to embrace the digital age because it's here. Think about your day-to-day. Patients come in because they found you where? Online. They might have watched a video that you put online, and then they went online and talked to other patients that might have been seen by you and said, yeah, this is where I'm going to go. So then how do they get reminded about coming to their visit? Through a digital device. They might even go on an app, right, to check their chart, check their medical record, maybe do a video visit with you. Coming to my clinic now, you got digital wall boards to educate you, right? And then checkout might be automated. Then you get another text message, online surveys. You see where I'm going. So, but it's a mixed bag, right? All of this technology and how it's dominating our learning. So there was a study out of Iowa where they looked at surgeons and surgery residents and students, and they found that 90% of everyone used video to prepare for the OR. And YouTube was the most common source. But if you go through the literature where they've assessed quality, in general, it appears that much of what's out there is deemed to be low quality. But granted, there are some studies that said that there is a high educational value if you look hard enough. But some of the scoring systems that are used more so outside of urology and general surgery and so forth, like Lap Vegas, have been criticized for their lack of relevance to using social media platforms as an educational tool. There is some value there, but it's hard to know what's good and what's not. Journals, do people read journals anymore, right? You'll ask residents and so forth about getting for Journal Club, have you gone through the latest New England Journal or all the papers in this month's Journal of Urology? And it doesn't work that way anymore. So they looked at over 100 pediatric surgeons and fellows in a randomized trial, and to assess the impact of reading a detailed manuscript versus watching a surgical video as it relates to improving self-confidence for an upcoming operation, okay? Both groups said that they improved their confidence from video, but only the attending surgeons improved from reading a manuscript. So again, it might reflect generational changes. So video does appear to be the best modality to reflect on your performance because you can actually see it, right? There's no second guessing and it's not based on your memory. And perhaps it's the most effective means to illustrate technique after the fact, right? There's also less of an investment as it relates to time and money than to go into building simulators and having these available at your center. We've seen in a number of these presentations today that it's used extensively. Why? Because it's eye-grabbing. You're always going to get higher ratings on your presentation if you include video clips. This has been shown. It's superior to verbal feedback alone, right? And people can say, well, I didn't do that during that case, right? You overcome the issue with denial. Assisted interpretation, having an expert there as well, appears most valuable, okay? Because now experience, like if I was gonna do an ablation and TJ's there and he's kind of going over everything, I know he's been there and done that. He has both the knowledge and the credibility. So let's talk about coaching. So having peer-based coaching, people that are in the thick of it, people that you respect, right, increases the accuracy of your assessment of surgical ability, okay? But again, barriers, we're all busy. Everybody's thinking about their time. Some people are worried about exposing, areas where they need to improve. They think about their reputation. They think about their image. And despite the fact that no hands went up thinking that they're the best surgeon, plenty of people feel like they're doing it as well as it can be done. We have a need for skilled coaches who don't make other people feel judged and people who are also coachable, okay? And so this is a challenge because we're all competitive people. We had to be, right? Getting into medical school was competitive. Getting into residency was competitive. Fellowship, competitive. Jobs, competitive, right? Instructional coaching seems to be more appropriate when you have a relationship that involves a veteran and a novice, whereas reciprocal coaching may be better when you have senior surgeons who are being coached. It's more bi-directional learning. It's less confrontational. You don't perceive this imbalance, right? So Michael Jordan, many people consider him to be the greatest of all time, the GOAT, right, for the NBA. And he said that his greatest skill was that he was coachable. He was a sponge and aggressive to learn. And his coaches at all levels, Phil Jackson and Dean, when he was in college, said the same thing. And so when we talk about post-game analysis, most people think about pro sports, okay? But post-game video analysis of surgical cases was reported to improve subsequent performance by residents as early as 1969. This is not a new concept, but yet we still don't hear a lot about it. There was a Harvard study, including Dr. Gawande, who a lot of people may know from just other editorials he's done in New York Times and other, but they used video playback and they had people that were determined to be experts kind of judge the performance and act as coaches, and they also involved a psychologist. And it was felt to be valuable by all participants and at all levels. Now, the concept of coaching, right, having a coach, think about, Harbaugh and, our Michigan Wolverines, national champions, thank you, implies a gradient in expertise, and it's likely best for junior surgeons, whereas just a post-game analysis is better for peer-to-peer discussions for people at a more senior level. And if you go back to when we had true M&M conferences, they've kind of evolved a fair bit. But the resident, even if he wasn't the one that was responsible for what went on in the OR, was the one that was, placed on the hot seat, right? Because it made the interaction less confrontational, okay? So it's a little bit of the psychology of it to make it palatable, right? To get better. So what were the items of interest in some of these studies? Well, the people that were asking questions, they were paid attention. They wanted to know about choice of incision, quality of exposure, operative technique, not only the technical factors, but decision-making concepts, right? What happens when you fail to progress and it looks like you're perseverating and not getting anywhere? And then troubleshooting when certain things come up. And then identifying chances for teaching, teachable moments, but sometimes you might need an additional camera a little bit away from the operative field. This was a great paper in New England Journal of Medicine, and I had trained with a number of these people, but they asked people to submit videos of their own cases. Now, this was after bariatric surgery, and everybody had to watch all the videos and rate them on a scale. And then the bottom quartile, actually, you could predict complications, operative time, and rates of reoperation. And it suggested that peer rating of operative skill could be effective for assessing surgical proficiency. Now, it wasn't just in other fields. We've done this in urology. So Peter Scardino was trained on coaching methodology and then had junior, intermediate, and expert surgeons ranked by number of cases go through 3 one-hour coaching sessions using intraoperative video. And they worked together to develop goals, okay? And, junior and senior surgeons focused on different items, things that they wanted to get better on, but everybody felt it was valuable and everybody felt it improved their self-confidence. And it was felt to potentially shorten that learning curve we talked about earlier for the more complex cases. So this was an interesting study or interesting project that was done by some researchers and presented at a non-medical meeting. They came up with this computer vision model. They used 280 some prostatectomy videos. And what they did was to create these nodes that allow you to compare, different people's approach at different phases of the operation. And if there was one particular part you wanted to go to, you could just click on that node. And people found that it improved their efficiency and self-confidence. So residents in particular like this a lot. But, I think about like the John Madden approach. So, kind of looking at this, showing what could have been done. So the video on the right is just something that I had posted previously about a surgical technique video. But what I do now is I have the in-light camera. So if my fellow's operating, I record him. And then we do side by side. And we'll pause it, fast forward, and go and say, look what you did here. What could you have done differently? So as far as tips and action items, I would say embrace the concept of continuous improvement, continuous professional development, right? Seek input from a respected source, even once you've finished residency, you've finished fellowship, okay? And you want to devote effort to intentionally focus on being coachable, to make sure you're coachable and you're receptive to new ideas. I mean, one of the greatest parts up here of the critique panel is, you hear a lot of discussion about, well, I never thought about it that way. I'm going to change my practice. I'm going to adopt this. I'm going to go home and talk about this. I mean, Mo was just talking about texting people back and say, are you doing this? We should be doing this. So, growing up, in a family of outdoorsmen, I was always taught to aim small, miss small, and I think the same applies when you're looking to make changes in practice, okay? But you want to give yourself credit for the wins, right? So it needs to be a positive experience as well. So I don't know if these guys are still around, but I remember the, Siskel and Ebert, kind of doing film critiquing, film review. So if you can get, people who know what they're looking at and have a good dynamic, maybe you can come up with some tips on how to get better surgically and feed off one another as like a symbiotic relationship. So with that, I thank you. Oh, you want to get a picture of that? I can send you the slide. It took me a little bit of work, a little cut and paste on the, And of course, I found those on an online search. So there you go, back to the digital. So, but that's all I got. So thank you very much.